Good. Okay. Well, thank you, everyone. It's great to be here and to have the opportunity to converse with all of you, and most importantly, to learn with all of you over the next 2 days. So I'm going to talk about evidence-based nutrition practice, and in particular, decision-making for both individuals at the clinical practice level and decision-making for populations. Good. Okay, so let's start with a clinical scenario. Imagine, if you will, that you're a primary care provider, perhaps a registered dietitian or a medical doctor. A 38-year-old male comes to see you who loves to eat meat. He doesn't actually consider a plate of food unless it has meat on it. His father was recently diagnosed with colorectal cancer, and he's concerned about his meat consumption given all of the media coverage on red and processed meat. He does tell you that he eats or consumes locally sourced forms of meat when he can to avoid potential environmental issues. You ask him to come back in a week or two, and in the interim, you plan to do a literature search and perhaps work with a librarian in order to find the best available evidence. So my presentation objectives are really to talk about what is evidence-based practice. We hear a lot of talk about this, and in particular, the principles of evidence-based practice. And in doing so, I'll talk about the Teagasc methods, but in particular, the GRADE methodology, which has been adopted by over 120 organizations worldwide, including the WHO, the CDC, the Cochrane Collaboration, etc. I'm going to use this clinical scenario to explore two things in particular: the magnitude of effect and the certainty of evidence for the magnitude of effect specific to colorectal cancer and meat consumption. And you'll find that evidence-based practice may often or is often at odds with many within the scientific community and, of course, with public perception. And I'll take time to explain to you, or at least try to explain to you, values and preferences, and what are value and preference sensitive decisions. My disclosures are, I've received startup funding from Texas A&M AgriLife Research in 2019 to look at saturated and polyunsaturated fat. In 2016, I took money from the International Life Sciences Institute to assess the methodological quality of guidelines particular to sugar intake using both GRADE methods and AGREE standards. I do not accept speaker fees or travel reimbursement from industry or industry affiliates, particularly because we're in the business of doing guidelines, and conflicts of interest, as we've learned, are very difficult to navigate. I am a member of both Teagasc and the GRADE Working Group, two groups that are really dedicated to a methodology, and in particular applied research methodology, so human research. And luckily, I eat without restrictions, approximately 1 to 2 servings of both red and processed meat per week, according to the Food Frequency Questionnaire. So what is evidence-based practice? The first tenet is really using the best available evidence, the most up-to-date, high-quality literature available to help you answer a structured clinical question or public health question. And so you need to be aware of the hierarchies of evidence pictured here, where systematic reviews tend to be at the top, and things like editorials and expert opinion are at the very bottom of the hierarchy. The second tenet of evidence-based practice is clinical or real-world experience. And the third is values and preferences of the client or patient, if you're working at a clinical level, or populations, if you're working at a, for example, dietary guideline level. Listed here are 8 principles of evidence-based practice. I have the great fortune of working with these PhD students at Texas A&M, where we teach a course in critical appraisal and evidence-based practice, and we really emphasize these principles. Today, I'm going to stress the latter 3 principles, but just to go through them quickly, 1, understanding hierarchies of evidence and causal inference. 2, understanding hierarchies of outcomes. Not all outcomes are equal, right? Biochemical markers are different than things like mortality. Framing answerable questions, searching the literature for the best available evidence, assessing the quality or certainty, assessing the quality or risk of bias for the available evidence. And then importantly, interpreting the magnitude and precision of the estimate of effect on an outcome by outcome basis, and doing the same on an outcome by outcome basis, looking at the certainty of evidence for that estimate of effect. And then finally, bringing into the fold the application of values and preferences of the client or the general public. So before we get into the evidence for our 38-year-old client, what is the quality of evidence, or what is the quality of systematic reviews that exist in the field of nutrition? Well, a recent study published in the American Journal of Clinical Nutrition in 2021 by Dena Zaratkar and colleagues essentially concluded that among 150 randomly selected systematic reviews in the literature, only 20% reported pre-registration of their study protocol. 28% did not report a reproducible search strategy. 26% did inappropriate meta-analysis or meta-analytic modeling. Less than 11% used an established system to evaluate the certainty of evidence, such as grade or Nutrigrade. And only 3.5% reported absolute estimates of effect. And so the focus of today's presentation is really on these last two items, certainty of evidence and the estimates of effect, ideally using absolute estimates in addition to relative estimates. So Nutrirex is essentially an independent group of individuals that have expertise in methodology, applied research methodology, nutrition, public health, medicine. And we have particular skills in systematic reviews, meta-analysis, and clinical or public health practice guidelines. We're spread around 7 countries. And this was our research question, particular to red and processed meat. We were interested in, of course, randomized control trials and cohort studies that enrolled 1,000 or more participants. As a prelude, we were able to find data to look particularly at 1.4 servings per week based on the RCT data, and 3 servings per week based on the cohort data. And in particular, we did dose response meta-analysis. So we looked at what is the risk reduction or the potential risk reduction in those that consume 3 fewer servings of red or processed meat per week. So if on average we consume 3 or 4 servings a week globally, what happens to our risk or important outcomes if we reduce by about 3? We thought that that was very reasonable. And then finally, we looked at studies that were based on cohorts that looked at dietary patterns, lower versus higher in red meat. Our population was adults with or without pre-existing cardiometabolic conditions, and our exposure comparator of interest was diets lower versus higher in red meat and or processed meat. Listed here are our target outcomes, 19 in total. On the left are what we would refer to as critically important outcomes or patient important outcomes, things like cancer incidence and mortality, cardiovascular mortality, stroke, myocardial infarction, and so on. On your right are things that we consider not so important. They're generally important, but we consider them to be surrogates. So biochemical markers, physiological markers like weight, body mass index, blood pressure, cholesterol, and so forth. The Nutrirex protocols are freely available. The more extensive one is published in BMC Medical Research Methodology in 2018. We've also published our protocols in Prospero, which is an online registry for systematic reviews. And the main output from our work was this guideline published in Annals of Internal Medicine, accompanied by 5 systematic reviews, also published in Annals of Internal Medicine. And essentially, our group concluded that with respect to red meat, the panel suggests, you can see here, this works. Maybe my pointer. The panel suggests that adults continue current unprocessed red meat consumption, and this was based on a weak recommendation based on low certainty evidence. We made a very similar or actually the same recommendation for processed meat. So among the 5 systematic reviews, there was 329 studies included. The systematic review on randomized trials included 12 studies looking at cardiometabolic cancer, quality of life, and surrogates. 3 systematic reviews looking at observational studies in particular cohorts. 1 study looked at intake, lower versus higher intake of red and processed meat for cardiometabolic outcomes, included 60 studies. 1 systematic review looked at intake, lower versus higher intake of red and processed meat for cancer, 99 cohort studies, and then finally a study on dietary patterns, which included 110 cohort studies. And then, of course, at the end, we did our systematic review on values and preferences with respect to meat consumption, and we found 48 studies. So everyone is very familiar with the 2015 WHO IRAC report, which was actually based on over 800 studies, many of them being mechanistic studies or rodent model studies. With respect to colorectal cancer, so imagine, if you will, you're the clinician and you go to look for the evidence on the risk of colorectal cancer. You come across the WHO report, and it essentially says that per 100 grams of red meat eaten daily, you have an increased risk of colorectal cancer by about 17%. This is a relative risk increase, which is very different than an absolute risk increase or reduction. This 17% was based on 10 cohort studies. And again, the mechanistic studies were considered a lot within the WHO report and were generally considered to be strong. With respect to the WHO report and the certainty of the evidence, so everyone will also be familiar with this, red meat was considered a group 2A carcinogen, meaning it probably causes cancer. So this was in many ways impetus for Nutrax. We really wondered about the quality of evidence that was available to support this public message. Now, how does Nutrax look at the data differently? Well, really, we owe a great thanks to the GRADE working group, because it's essentially their methods that we've used. And the first thing to consider when you're thinking about the magnitude of effect and the certainty of evidence for that magnitude of effect is what you're actually grading. And the GRADE working group says we're not assessing our certainty in the point estimate of effect, but instead we're looking at our certainty in where effects lie relative to something referred to as a minimal important difference, which is very different than whether something is statistically significant. Okay, so you can look at things relative to the null effect or relative to an estimate that we consider to be on average important to either a patient or to a population. So a priori, we chose thresholds in terms of what we consider to be important. We considered that anywhere from 11 to 25 cases of fatal outcomes per 1,000 followed over a lifetime was what we called a small but important effect. And for non-fatal outcomes like colorectal cancer incidence, we considered anywhere from 21 to 40 cases per 1,000 followed over a lifetime to be a small but important effect. Right, so again, very different than considering whether something is statistically significant or not. And there's been a big call in the literature to move away from p-values and statistical significance, particularly in clinical research or public health research. So this hopefully illustrates things a little bit better. So this is the data from our systematic review of randomized control trials. Just one randomized control trial, Women's Health Initiative, almost 49,000 people randomized. With respect to colorectal cancer, the best estimate of effect was 12 fewer cases per 1,000 followed over a lifetime for total cancer mortality. But that estimate ranged anywhere from 26 fewer cases over a lifetime to 2 more cases over a lifetime. So not statistically significant, but you can see that I'm not sure if that's working here. You can see that an important difference, which is 10 fewer deaths as the threshold.
You don't have the microphone anymore before we're
yeah. That's good. Thank you. Maybe I'll just stay at the podium. Very important considerations. So let's talk a little bit more about the certainty of evidence and how we arrive at the certainty of evidence for a particular estimate of effect. So traditionally, we had the hierarchy of evidence, which goes back 30 or 40 years ago. It's a kind of a static system, systematic reviews at the bottom, expert opinion at the top, or sorry, systematic reviews at the top, expert opinion at the bottom. Along comes grade about 20 years ago, which is a more sophisticated method to look at the certainty of evidence for an estimated effect. And in particular, if you have a systematic review of randomized controlled trials, you start at high quality or high certainty evidence. If you have a systematic review of observational studies, we tend to start at low certainty or low quality evidence. However, there's a bunch of factors that we need to look at in order to see if the evidence may go up or down. And ultimately, we arrive at the overall certainty of evidence as high, moderate, low, or very low. So you can kind of imagine it starts with the traditional hierarchy of evidence, but then that evidence can move up or down based on different factors like risk of bias, inconsistency of evidence, publication bias, etc. And ultimately arriving at high, moderate, low, or very low certainty of evidence on an outcome by outcome basis. So let's get back to colorectal cancer incidence based on our systematic review of RCTs, just one RCT, Women's Health Initiative, 48,000 women followed. Essentially, the relative effect is not statistically significant. And in fact, when we look at the risk difference, the absolute risk difference or absolute risk, in this case, increased 3 more cases of colorectal cancer per 1,000 people followed over a lifetime. But that ranges anywhere from 7 fewer cases to 18 more, so not statistically significant. So essentially, we're very uncertain based on this one large randomized trial. And the certainty of evidence, as you can see here, was considered to be very low. Looking at our systematic review of cohort studies, particular to colorectal cancer incidence, where we looked at a dose-response meta-analysis. We used a dose-response meta-analysis to look at 3 fewer servings of bread and processed meat per week. The relative estimate is right on the null line, so 1.0, which converts to a risk difference of 0 fewer cases per 1,000 people followed. And of course, not statistically significant, and the certainty of that evidence was considered to be low. And finally, our systematic review of cohort studies that looked at dietary patterns. Again, this was 110 studies. For colorectal cancer incidence, we found a relative risk of 0.94, again, not statistically significant, ranging from 0.85 to 1.05, which converts to a risk difference of 1 fewer case per 1,000 people followed over a lifetime, ranging anywhere from 3 fewer to 1 more. And again, very low certainty evidence. Some of you might have noticed the evidence further up on the table for overall cancer mortality. In this case, we have a risk difference of 12 fewer cases per 1,000 people followed, ranging anywhere from 18 fewer to 4 fewer. Again, certainty of evidence very low. And I think everyone here knows the issues of confounding within cohort studies and why one might arrive at very low certainty evidence. In this case, the certainty of evidence was considered to be very low because of heterogeneity, a lot of inconsistency between the cohort studies. We also looked at the best estimates of effect, the magnitude of effect with respect to our cohort data, 3 fewer servings versus our dietary pattern data, which looked at dietary patterns lower versus higher. And essentially the estimates are almost identical. So 7 fewer cases per 1,000 and 12 fewer cases. Sounds like maybe there's a bit of a difference there, but that's 0.7% and 1.2%, almost identical. Again, based on low certainty evidence. So now that we have a sense of the evidence, the magnitude of effect for colorectal cancer and the certainty of evidence for colorectal cancer, we now need to move from an evidence-based perspective to values and preferences. What do we mean by values and preferences? Well, from a clinical perspective, it's the values and preferences of patients and clients, those who are going to bear the consequences of either reducing their red meat or not. And from a public perspective, of course, the general public. In particular, when I say value, it can be defined as the relative worth, merit, or importance of outcomes, health outcomes. So for example, how do you trade off personally, or how does our 38-year-old client trade off the risk of cancer versus dietary satisfaction? And when we say preference, we essentially mean a greater liking for one alternative over another based on the magnitudes of effect, if the patient knows it or the public knows it, and the certainty of those magnitudes of effect. So that's, you can't make value and preference sensitive decisions unless the patient knows what the evidence says. And it's the same at a public health guideline level. So of course, we did our systematic review of values and preferences. And although there was 48 studies included, perhaps the most interesting ones were qualitative studies, 3 studies out of Portugal, Scotland, and Australia, all in omnivores. Again, the certainty of evidence was low. There was risk of bias issues with respect to a lack of reporting of the investigator-participant relationship, and there was indirectness, meaning they often didn't talk about what specific type of meat or what specific health outcome. But essentially, the bottom line, overall, most omnivores often mentioned that taste of meat, the perception of meat as part of a healthy diet and as part of their culture and tradition really kind of drove their decision-making. And so we come back to our clinical scenario. So what advice would you give your 38-year-old client? So I'll leave that to you to contemplate, but just a few more slides that I'll run through quickly. So ideally, decision-making should be driven by decision aids like this, where the client or the public has a very clear understanding of the outcome of interest, the certainty of evidence for the outcome, and the magnitude of effects. So here, for the outcome, overall cancer mortality, 7 fewer cases per 1,000 people followed based on low certainty evidence. And we've indeed used these types of decision aids in 3 national studies, one out of Canada, which was a pilot study published recently, just 32 participants, but essentially we shared these decision aids with members of the public, and the results, bottom line result was none of the participants were willing to eliminate red or processed meat from their diet. About 1/3 were willing to potentially reduce their consumption. A second study out of Poland, much larger, over 500 people enrolled. Conclusion, when faced with health information about uncertain reduction in the risk of cancer mortality and incidence, the vast majority of study participants were unwilling to introduce changes to their meat consumption. And very similar study, same methods that we did in Spain, and had the same conclusion. Authors, myself being one of them, so I'm biased. You have to be, maybe you shouldn't believe this, always having a critical eye. We concluded that public health and clinical nutrition guidelines should ensure that their recommendations are consistent with population values and preferences. And these 3 studies come out after the Teagasc dietary guideline. So there's been lots written on the politics of red and processed meat guidelines and recommendations. This is a wonderful article that was an in-depth investigation of just what the politics were from both sides, or at least some of the politics. Wonderful short read. This is a second short read where we've written about trying to reconcile contrasting guidelines on red and processed meat. Another, I think, again, biased, but a nice short read in terms of also understanding what's the difference between consensus-based guidelines and evidence-based guidelines. Everyone says that they're evidence-based, but hopefully after today, you have a better sense of what we mean by evidence-based. And we've also done a video synopsis of the methods and recommendations based on red and processed meat. And recently, our English video has been translated to Italian, and Andrea can tell you more about that. And finally, I'll just end by saying methodology and patients first. That's our perspective. Recent study in the Journal of Clinical Epidemiology that talks about methodology over metrics, and that current scientific standards are a bit of a disservice to patients and society. And there's room for improvement with respect to dietary guidelines. I want to acknowledge the large team of Nutrirex investigators from 7 different countries, including our wonderful trainees, who many have already moved on to be doing very great things, given that we published our stuff back in 2019. And with that, thanks very much for your time.